Good evening. It's the last session from ICEM Day 1. Welcome you all. I'm Nilanka from Sri Lanka. So it's about innovative teaching, one of the most trending topics at the moment. To my right side, welcome Dr. Amjad Obeid from Bahrain. I have been teaching since I was 2. What I have learned at the nursery, ABCD, I was going out and teaching to my parents and everyone. And today, it has been developed up to this level. So I'm involved with the AI and teaching, and I'm involved with the innovative teaching. And the ICEM and IFM has selected me to sit there. So yes, I'm still a trainee in emergency medicine, final year trainee. We have done a lot of training, innovative teaching at a platform called Emerge. Welcome you to see at the marketplace. You'll find more about me and the platform Emerge Sri Lanka. So we welcome you, Dr. Amjad. We are very enthusiastic to learn what's new about this traumatic brain injury.
Thank you very much. I appreciate it. Thank you very much. Learning is a continuous process. Till the last day of your life, you should just go on and learn every day new thing. So we'll talk about updates and TBI management. It's the path to precision care. So I've got nothing to declare, nothing to disclose. I've got no affiliation with any company or anything. I'm just gonna go a few tips about TBI. All right, is TBI important? Is it something important for us? Yes, it is. It is something that we face it in emergency medicine. Imagine it, we've got 60 million cases every year that happen around the world. Imagine 60 million patients coming with patient with TBI. And the cost about $400 billion. Imagine $400 billion are spent for care of TBI patients. And it's not only that, it's becoming, and now TBI is not only a trauma on that day, it's becoming a chronic disease. And somebody who's having concussion, which is going to come to it in a moment, they are suffering from their injuries. It's a chronic disease, and that will be even further burden on our cost and of course on our existing health facilities. So what shall we do? This is statistics from the US. This is what I got from the literature. 4.4 million visits in ER, about 214,000 hospital visits in the US, and of course, all the resources are being shifted towards treating our rehabilitation of the TBI patient. Although that's all because we did not diagnose concussion or mild traumatic brain injury early. That's why they are turning into, instead of them being cured, they're becoming to a chronic disease or chronic patients that we are facing them in our emergency every day, because we lack or we did not diagnose them at that time. Let's go. So what we have is that, as I just told you, it's about 4.4 million visits in emergency departments in US. So there are lots of guidelines. So they said it's not only a disease that we have, it's not a fantasy just to talk about TBI. It's not only neurosurgeon about it, because we are part of the medical care of them. There are lots of guidelines which been developed by the BTF, which is the 4th edition, and by the ACS, American College of Surgeons, the Trauma Quality Improvement Projects, and lots of clinical integrations, clinical guidelines were developed just to enhance our medical management for patients with TBI. Let me just tell you, emergency medicine, we call ourselves as the safety valve of the whole hospital. We as emergentologists all over there, if we did not diagnose, if we did not really pick up the patient early, lots of the patient even could suffer for a longer period of time. And of course, that would be more burden on our healthcare facilities. No. So mild TBI, concussion, which is the silent epidemic. Imagine this topic is something really killing. So because it's something which is very, very important and it's very crucial, 2023 ACEP developed a clinical guideline for that. There's a CDC as well, standardizations. There's a primary goal just to have to always detect the long-term cognitive. What happens in TBI, mild concussion, patients are gone there without being recognized. We can see many of the athletes, many of the boxers, motor sports, football, American football. They had a mild traumatic brain injury on the scene. They did not lose consciousness. They did not have anything. Oh, we are fine. I just knocked my head down and then go home. And after a couple of months, they deteriorate psychologically. They get divorced, they leave their work, and they go to psychiatrists, they go for treatment, antipsychotic medication, and they go for even for addiction. And many of them actually even dropped their career, and that was only because of a brain concussion, which we did not diagnose at that time. We did not pay attention that it's a mild TBI. Yes, patient does not need a CT scan right now. Yes, he's have got no neurological deficit, but he sustained a concussion that we did not recognize it. I always have got one of my professors says, the eye does not see what the mind does not know. So if we think that we've got a TBI patient, this got a mild concussion, we did not recognize it, this we might even affect all his life all over. He might just, as I told you, leave his job, go to depression, divorces his family, and imagine that deterioration of his life. So we have to pay attention to mild TBI, and always have kind of a good I mean, you have to have a kind of vigilant for this issue. So what is it, the diagnostic tools now and the future? I'm not talking about future, but something is very important. Of course, CT scan, anybody coming who banged his head, very important. We've got very clear guidelines, Canadian guidelines. Anyone comes with head injury, fall down, loss of consciousness, CT scan is just a kind of an easy thing to order it. Will we order CT scan for somebody with a mild trauma in his brain or not? That's very significant. Now this comes to the serum biomarkers. I'm not promoting for any companies, but there are serum biomarkers which can be as sensitive, and they can raise within 1 hour of the mild brain injury. So we call it like at school. Some of the kids are playing soccer, they bang their head, they fall down. Do I need to take him to the hospital to do a CT scan or not? We talk about, I do lots of motor sports. Somebody had a driver had a kind of a high impact injury, but he's fine. He came out of the car walking, got no complaint. Could he be having a concussion or not? As I told you, concussion is the silent epidemic. If we did not diagnose it, we did not put him on the right path, the right follow-up, we are going to lose this patient. So serum biomarkers, there are several serum biomarkers which can be positive within 1 hour of the injury itself. And imagine it's like what we call it a troponin for the heart. It's a troponin for the brain. Okay, there are serum markers that can be elevated within an hour. Okay, it can be an iStat, an handheld device with you, whether it's a pre-hospital or it's somewhere far away that you don't need to transfer the patient, can detect. If there's any raise of those serum markers after the concussion, then you can take this patient to the hospital, do the CT scan, put him in the proper pathway, let him be followed up, rather than just ignoring it. Well, we are fine, just go home, you'll be okay. And then after a couple of weeks, the behavior has changed, the patient becoming so totally another person. So serum biomarkers, it's kind of a tool. It's available. Nothing has been there for a long time, but now it's an FDA approved. Neurotransmitter is very important, as I just told you. Neuroimaging, yes, is not only a CT and MRI, functional MRI, because MRI will just give you the structure about the function. What is the fMRI? Is it there's the oxygenation of the blood vessels, the MRI? Something very important. A step further. Are we only evaluating the structure, or the function as well? And of course, lots of point of care. As I told you, those serum neuromarkers are point of care, handheld. We've got AI generated to interpret our imaging. The early diagnosis or the quick diagnosis will prevent lots of complications that could happen to our patients. So what we can do is that the treatment stuff from pre-hospital. If we've got a pre-hospital care, if we've got a patient who's kind of 2 hours away to go to the hospital, if our pre-hospital personnel is equipped with a handheld device, they check our serum biomarkers. While it's positive, I think he's got a positive biomarkers. He needs to go to the hospital to CT him and go on with the concussion program. Emergency department. As I told you, we emergentologists, as emergency physicians, we detect. We are the first, we're the frontliner. We are the safety valve of the hospital. I always say this very proudly, that we diagnose our patients, we detect them, we have got a high index of suspicion, we put them through the right path. And of course, later on, the proper setup of the neuro ICU, neurologist, neurosurgeon, psychiatric as well, they all are part of that. And of course, we end up with the rehabilitation. Does this patient, yet he did not have any neurological deficit, in the rehab, he needs to go for a session because it can even affect him psychologically as well. Okay. So blood pressure. Now another guidelines for the treatment. So when you have a head injury, it's not only neuromarkers. We talk about mild brain injury. Now we talk a little bit more than mild brain injury. Blood pressure targets. Are we happy to lower blood pressure? Do we accept a low blood pressure for patients or not? Before we said no. Well, we don't always think of secondary brain injury. It's not only the first time which he has got sustained an injury. We've got to talk about the secondary brain injury. Now they have got a new guidelines which was developed by the BTF, which is ages, different age group, age from 60 to 50 to 69. The target is about more than 100 millimeter mercury. From 1 to 49 and above 70, we talk about 110. All the standard was we have to be less than 90. Yes, hypotension can be the second problem as well in your brain injury. So do not keep your patient hypotensive. So you don't want to have another secondary brain injury to our patients. So what we always say, there is no such thing that acceptable that hypotension and severe TBI. So you don't want to have another injury to the brain tissue. You need to have a good, a reasonable blood pressure which sustains perfusion. Once your blood pressure is lowered, your perfusion is going to less, and that will even cause a secondary brain injury, and I think we all agree on that. Of course, not only blood pressure, of course, we talk about hypoxia as well. Intracranial pressure management, we have to always have the monitoring devices for our intracranial pressure management as well. I'm going to quickly just go through other slides as well. So how we can do the CPP, we always have to have a CPP which is reasonable, from 60 to 70 millimeters mercury. We should not be lower than that. I should not be even higher than that. If we go on, wanted it to be above 70 and keep on pushing fluids, we can end up with having an ARDS as well. You don't wanna manage a problem with his brain and let him go to an fluid overload. So always be reasonable. But of course, there's something very important in our patient which is called the autoregulation. This is it's our body's response, the natural thing in our body, which is called the autoregulation. So this is the hidden key. It's not only a target. It's not only one menu or one prescription to all patients. You have to manage your patients. Let his autoregulation system take over. But you have to always have a target. 60 to 70 millimeters of mercury, that's enough to perfuse your vital organs, especially your brain as well. And of course, when you go to an advanced cerebral monitoring, we go to a neuro ICU, a specialized one that you don't want the patient to be unmonitored as well. Surgical, do you need to go for craniotomy or not? That's a different, lots of old school. Nowadays, they did, if there is no benefit for the patient, why should I go to surgery and expose them to more danger as well, or infection as well? If somebody is gonna be for the rest of his life, I know he's young, releasing his pressure by doing a surgical intervention, want to release the pressure, but he'll be living or the rest of his life as bedbone or vegetative state, that we need to also judge as well. The issue is that medicine is not only doing the right thing for the patient, the right thing for the patient at the right time with the right resources. You don't want to exhaust all the resources for patients, and at the end you're not going to benefit with them as well, exposing them only for dangers. So early intervention is very important. I just want one more slides. A multidisciplinary effect for our patients. Involve all your team, whether it's an emergentologist, anesthesia, neuro ICU, the surgeon should be there. Always recognize the mild traumatic brain injury as well. Do not miss it. And of course, don't forget about rehabilitation for our patients. Impact, once we have a good impact, once we have a good follow-up for our patients, you will not miss such patients. Lots of future are there for our TBI patients. The introduction of the neurotransmitter, the handheld, the point of care management is very important. The recognition among all emergency physicians about mild traumatic brain injury makes a big difference in preventing chronic diseases. So I will just skip this. To summarize that, we have to adhere to our advanced protocols, respect the autoregulatory for our patient. Not only when we don't give numbers, we treat patients. Don't say it has to be 70, we won't say its blood pressure has to be 110. We have to give chance to our autoregulation, that the body will adapt himself, and of course, don't forget that it's a chronic disease. TBI is a chronic disease if not well recognized at the beginning. To conclude, always make sure that you always diagnose your patient, have a lower threshold to diagnose your patient, put them into their path, and of course follow up all the protocols. Those are some of the protocols of the ACS and the TBF, traumatic brain injuries as well. They have to make familiar with that, circulate them to your doctors and your staff in the hospital. And I will conclude my talk. Thank you very much.
Yeah. Thank you very much. I think that's what we call learning from the experts.
Thank you.
I really love this role reversal.
Thank you very much. But it's a longer topic, but it will need a longer time. But I just get it only a few points that I can go later on and explore it more.
Okay,
thank you very much. Thank you for having me. Thank you.
So let me introduce our next speaker who is joining online, Dr. Lama AlFakhri. She's from Saudi University Medical City, and she's also adult and pediatric emergency medicine consultant. Over to you, Dr. Lama.
There's a lot of consults that need to be done. To top it all off, an interested intern approaches you and tells you, can we please discuss a case that we just had? We've all been through this situation. So what would you do in such a case? Would you actually discuss the case with the intern? Or would you ask them to read the room, and once everything calms down, you would actually discuss the case? So why is teaching on the go important? It has been proven to help with the patient outcome. It boosts the engagement of learners and fosters team dynamics. But what are the barriers that we could face? As emergency physicians, we have a lot of time constraints and high workload. We also have unpredictable scenarios and cases that could come up suddenly. We also have varied learner levels in our team. We have students, juniors, seniors, up until fellows as well. And you, as an educator yourself, you might have self-doubt of whether or not what you are teaching is actually relevant in this particular case or in this shift. So I would like to concentrate on evidence-based micro-teaching toolbox that helps make the best out of your shift while running the flow smoothly. Keeping in mind that teaching does not have to be time-consuming to be effective. So, beginning of the shift, let's start the clock. Okay, so now your first tool, this is the first tool, the 30 seconds learning agenda. You're getting to know your team members. It usually takes around 30 seconds to get to know their agenda. You could actually ask them, what's one thing you would like to focus on today? This tailors the shift to individual learning needs, helping in keeping their focus. The second tool is you spot it, you teach it rule. In this tool, once you speak to your team members, you would ask them if there's something that catches their attention or anything that they find interesting. You would like them to read more about it so they can actually explain it to the rest of the team, as this tool can turn observation into active teaching responsibility. Okay, so we've reached the middle of the shift. It's getting more hectic. You also have a procedure. So a procedure learning framework, in this tool, the evolution of the procedure skills from C1, do one, teach one, to Sawyer's 6-step framework. Now, the traditional model emphasizes learning through clinical exposure, whereas Sawyer's 6-step framework, which includes learn, see, practice, prove, do, and maintain, this emphasizes on competency-based training rather than observation-based learning, as well as improving both learner outcomes and patient safety. Technology as a teaching aid. In this tool, you could use applications, short videos, and clinical calculators to supplement micro-teaching. Let's say you get a patient with an ankle sprain, for example. You would ask your trainee to evaluate the condition of this patient and whether or not this patient needs an X-ray using the Ottawa ankle rule, for example, using the clinical calculator. So this reinforces learning without draining the shift time and combines blended learning with bedside teaching. Think aloud. In this tool, this refers to verbalizing what you are thinking out loud, which helps learners understand the rationale behind the clinical choice, which helps in developing their own critical skills. In the 1-minute preceptor tool, this tool is designed to enhance the quality of information delivered in a short amount of time, emphasizing on brief, focused teaching moments through a set of 5 skills. So let's say you ask the learner to commit to a diagnosis or a plan. What do you think is going on with this patient with chest pain, for example? You will move on to assess the clinical reasoning. What led you to that conclusion, and why do you think that this patient actually is high risk for acute MI? You provide 1 to 2 teaching points. So you would say, if you think this patient has TEMI, for example, why not provide this patient with aspirin? You provide a positive feedback. You would say, I like that you actually asked for an ECG early on. And lastly, you will address errors constructively. You would say, if you think that this patient is having a STEMI, I would like you to tell me early on, so we would activate the cath lab. The culture and role modeling tool. This transforms role modeling into super modeling. This is a mnemonic that is summarized in super, which S is for self-awareness, unconscious becomes conscious, plan, debrief, and encourage reflection, which I'll talk about in a bit. In this tool, this fosters a safe and a supporting learning environment. So learners would actually learn from you and observe the way you act with the team members, the family, and the patient. They would actually see the skills and your attitude without having to say anything directly to them. Okay, so we've reached the end of the shift. Let's wrap it up. Okay, so in a case reflection, this shifts focus from volume to actual meaning, okay? So you would actually ask your trainee, which patient today taught you the most and why? As even 3 minutes of reflection creates a long-term impact. This reinforces reflective practice. Emotional debrief tool. In this tool, this supports the emotional well-being of the learner, especially after tough codes or resuscitative cases. So this maintains their emotional wellness. You would ask, what moment hit you the hardest today? Anything you're still carrying from that shift? Lastly, I'd like to conclude with this. Your shift is your classroom. Make every shift count. Thank you.
Thank you very much, Dr. Lama, for
Thank you
taking
very
through your shift. We enjoyed with each step in your shift from the beginning to the end.
Thank you.
And it reminded me some of the similar innovative teachings in the Emerge Sri Lanka platform as well. So impressive.
I'm glad.
Hope you will be with us together for the discussion at the end of the session.
Sure.
We are moving towards our next speaker, Dr. Victoria Di Siervi from Argentina. She's a consultant emergency physician. She's going to talk about the most trending topic in innovative teaching at the moment, AI-driven innovative teaching. So over to you, Victoria.
Okay, thank you. So we have the presentation? Yes. Okay. Well, my name is Victoria Siervi. I am an emergency physician from Buenos Aires, Argentina. Before I begin, I would like to disclose that I have no conflict of interest related to this presentation. Today, I would like to explore how simulation can be enhanced by AI and complete clinical competency development, particularly through the lens of educational accessibility. I briefly outlined what we will cover today. First, we will describe the training paradox we face in emergency medicine training and why developed competencies remain such a challenge. Then we describe the competency we aim to achieve during training and why simulation becomes such a fundamental training tool. I will share with you some practical application of these models, and then we can discuss how can we move forward and meaningfully integrate these models to our training programs. I don't know if the slide on. So, emergency medicine training is faced by a fundamental paradox. We are expected to be prepared for some of the most critical situations in healthcare. High acuity, low frequency, and high risk events that leave a very little room for error and requires rapid decision making. And also, the exposures to these situations during training are highly variable. So, acquire competencies only through clinical exposure will not be complete for our training. So how do we create these opportunities? Well, thinking training only on theoretical knowledge acquisition, it must be an error. It must focus on clinical competencies. And when we talk about clinical competencies in emergency medicine, we are talking about a multidimensional world because it includes technical skills like airway management and resuscitation, but also includes non-technical skills like teamwork, cognitive agility, leadership, and situational awareness. So, by clinical exposure, we can acquire all the competencies remain for a good emergency practice, and this is why simulation matters. Simulation can help us to make scenarios that can be repeated, be more dynamic, and the evidence supported simulation training because research has demonstrated that simulation improves knowledge acquisition, procedural skill, and team performance, and when combined with deliberate practice and effective feedback, it becomes such a fundamental tool. Simulation alone is a great strategy for training, but technology in the last 2 decades has enhanced simulation and made more effective, more scalable, and more dynamic. The impact of these new tools improves knowledge acquisition, procedural performance, clinical behavior, and even patient-related outcomes. And this evolution of simulation creates the foundation for the next steps, AI and adaptive guided simulation. So, if simulation is already an effective tool for training, what already artificial intelligence add? To answer that question, it's useful to compare traditional simulation with AI-guided simulation. Traditional simulation have static scenarios, instructor-dependent feedback, and the clinical progression is often predefined. But in AI-guided simulation, we can generate more adaptive scenarios. Scenarios can be more dynamic, feedback can be generated in real time, and learning pathway can be more personalized. It's allowed us to train decision-making and clinical reasoning in a more dynamic environment. While this technology offers a lot of opportunities, also came with limitations. Limitations that we must acknowledge. There are technological limitations, like infrastructure availability and connectivity constraints. There are also educational limitations, like faculty training and prompt quality. There are scientific limitations. We still need stronger data for long-term educational and clinical outcomes. And we must focus on ethical and operational issues like data governance, standardization, and potential bias. I will share you some practical application of these models. One especially application is XR simulation. We developed an XR-based triage simulation while combining extended reality with AI systems, we can create mass casualty scenarios where trainees can assess multiple victims, prioritize care, and allocate resources. The trainees can practice in real time, and this situation is often so difficult to reproduce by only clinical exposure or traditional simulation. Also, we can generate remote adaptive learning scenarios that can be complete asynchronously from virtually any location. We can use an structured prompt, and AI can present the clinical case, describe the scenario, describe the patient, and give the trainee a specific task. The trainee must assess the task, and based on the learner response, AI can make an structured feedback and highlight strengths and weaknesses and subtitle areas or for progress. We can also power AI virtual patients. This is a specific prompt we can power and instruct the AI driving system to behave as a patient, and training can be interact through voice or text, and can do decision making, clinical reasoning, history taking, and AI virtual system give the trainee a feedback based on clinical competencies and communicational skills. And one especially promising application of these tools are hybrid simulation ecosystems. We can combine AI driving system with high fidelity simulators that give physiological realisms, while AI driving system can give more dynamic scenarios and evolving clinical progression. This creates a richer and more interactive learning environments. These applications are only a small portion of what can be achieved with AI-guided simulation for competency development. If you want to explore some practical application, practical prompts, or see these tools in action, we can scan the code on the slide. The integration of these tools can be across of the different training strategies of medical training. At an undergraduate level, they may support clinical reasoning, structured assessment, and early emergency exposure. And in a postgraduate level, they may support crisis resource management, team leadership, and high acuity decision making. And these tools are particularly relevant for low and middle income countries like mine, Argentina, because traditional simulation is often require a high cost infrastructure and maintenance. Instead, AI-enhanced models are more portable, scalable, and low cost. This acquires permit simulation can go beyond specialized centers and can be achieved in outpatient settings, smaller institutional environments, and even in learners' home. So how can we move forward? The successful application of these tools will require more than technology alone. We require a successful educational strategy, faculty development, curricular integration, and structured feedback systems, but also require longitudinal implementation. So thank you for the attention, and if we have any comments, questions, we can contact me in this email address. Thank you.
That's wonderful, Dr. Victoria. I think since the beginning of the ICEM, since yesterday workshops, we have been hearing about AI and
Yes.
emergency medicine. We had one workshop, and then we had hackathon, and I think now the results are ongoing to see who is going to be the winners. I see so many things common between you and me, your interest and my interest, of course, from being from the low middle income countries.
Okay.
That's like so many similarities, so many opportunities for innovative teaching. So before we conclude, we'd like to open the session for the audience for any questions. Or anyone from online? So I would like to ask you, Dr. Victoria, so you told you have been into AI and emergency medicine for a long time now. So when you compare with the past, and what are the feasibilities you see with this app development and AI in emergency medicine at the moment?
Well, AI images are a little bit more complicated than PowerAid simulation strategy because we need high specific task, and you can use them as a decision-making strategy from real patients. And I think well you are designing so platforms for images can be visualized and interpreted by an AI systems. I think this can be such a fundamental tool for ER physicians like me that don't have an images specialist with with me in the turn, yeah, when I am in duty. An AI driving system can be so useful to emergency physicians to enhance image description and for complete decision making with the physician.
Yeah, it's time saving and helping tool, but I don't agree that it will replace us.
No, not going to replace us.
Okay, thank you very much.
Thank you.
And Dr. Lama, are you still there, right? Dr. Lama? Yeah, it was lovely to see your teaching. So, like, it was from the beginning to the end of the session. Like, the shift you have had different innovative teaching styles incorporated. So, I'm just a little bit curious to know, like, are you going to imply, or do you imply all the methods at one go, or like randomly one or two per session?
On how the shift goes. That's why we made it as beginning of the shift, the middle of the shift, and the end of the shift. You can just go on, use any tool randomly, whichever you feel comfortable more with.
Yeah, that depends on the busyness and the
Of course, and the
appropriateness
workload you have, the learner barriers. So yeah.
and just like would like to know how your trainees respond to the innovative methods of teaching.
It actually is very helpful. A lot of trainees learn a lot, and it depends on how the shift is going. But they usually learn a lot after the shift.
Yeah, I think they love the teaching. So like I think they
Find
they
it
might have
very,
given yes.
yeah, very fruitful, and they're actually very interested to take more shifts with us.
Okay, that's wonderful to hear. I think Dr. Ajmad is not here to be seen. I think it has been a very informative and like very looking forwards with innovative and AI and so many things to be carried home with this session. So thank you very much, everyone. Thank you, the audience.
Thank you,
and
Nilanka.
thank you, the speakers.
Thank you.